For the last few months, I've been stuck, really unsure how to end this season on primary care. I thought I needed to wrap things up in a way that offers a path forward. But the whole time I've been reporting on primary care, I felt like my role in the project wasn't to offer solutions. The solutions are out there. They've been out there for decades. So the question in my mind has always been, why haven't we adopted them? And I felt like my task in this reporting was to answer that question. But then something happened to me over the last several months in the process of putting together the podcast. Maybe it was your emails. Maybe it was watching AI reach another inflection point, leaving me even more clear-eyed about the importance of human relationships. Maybe it was listening to hours and hours of tape, beginning to see a pattern, an ache in people's voices, a love, a sense that despite the many challenges, clinicians still felt called to the work of primary care. And I found myself beginning to wonder, was my question based upon the wrong premise? Meaning, was primary care even a problem to be solved in the first place? I'm not saying primary care doesn't have problems. It has so many. But when Kurt Stange, a family medicine physician you heard from earlier this season, wrote me an email last November, something shifted for me. And what Kurt wondered was whether those trying to help primary care become part of the problem when we, quote, frame primary care as a problem to be solved rather than a treasure to be supported and understood. I'm not sure I totally agree, partly because I don't know how to fix problems without calling attention to them. And also because I'm not sure how to treasure primary care in a way that's both genuine and galvanizing. I could go on and on about the beauty of long-term relationships, the gratification that comes with meeting a community's needs, the stories of diagnoses made before it was too late. But even I, with a massive capacity for being overly sentimental, can only engage in so much of this type of treasuring before it starts to ring hollow, or worse, minimizes the very real structural challenges primary care clinicians face, as if the answer is just to try harder to be happy, which is a really annoying thing to be told. And so there I was, trying to maintain this tenuous balance between considering the problems and sustaining the joy, feeling stuck. Which is how I found myself at 10:30 in the morning on a Friday, telling myself not to open Twitter, then, of course, opening Twitter and clicking on a video of Alysa Liu's Olympic free skate. To be clear, I know nothing about figure skating. I'd never even heard of her. So maybe that's why I was so surprised by my own reaction to the video. Because watching her skate was to experience the most transcendent joy. It was so pure and so beautiful. And by the end, I had tears streaming down my face. And I wasn't even sure why. But when I learned her story, I found myself wondering whether the themes of her life offered a framework for thinking about the future of primary care, a way to reconcile the need to address structural problems with the dueling imperative to maintain meaning and joy. So what's Alysa's story? Alysa's 20 years old, and she was mostly raised by a single father who came to the U.S. 35 years ago from China as a political refugee. At age 13, Alysa became the youngest U.S. women's figure skating champion in history. A few years later, COVID hit, and though her father spent hundreds of thousands of dollars sending Alysa all over the world to train with the best, she felt lonely, stripped of her freedom, disconnected from her passion for the sport. So at age 16, she retired. And when she decided to return 2 years later, she did it on her own terms. She would choose her clothes, her music, her coaches, her food. And her focus would not be on winning medals, but instead on artistry and joy. As the New York Times critic Gia Corliss wrote after Liu's captivating performance, even if she hadn't won the gold medal in figure skating at the 2026 Winter Olympics, and she did, amazingly, with no nerves whatsoever, Liu was always going to be its shining star for the way her skating is driven by love. Of course, Alysa did win the gold, yet as Corliss points out, the gold wasn't what it was about. And for primary care, I think a similar dynamic might be at play. Not only have I come to believe that primary care's true value can't always be captured by extrinsic measures of success, but I also worry that in our ongoing quest to define primary care's worth, we risk undermining what makes it so valuable in the first place. And so that's what we're going to talk about today. What actually makes primary care so valuable? What happens when we try to quantify it? And taking a cue from Alysa Liu, what principles might allow primary care to focus on what matters rather than solely upon what we can measure? I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. For Alysa Liu to skate on her own terms, she first had to recognize that she had some agency over her life. And though we've talked a bit this season about agency and primary care in the context of leaving traditional practice, we've talked less about what agency looks like for those who stay. Jonathan Hahn is a family physician at the University of Pittsburgh Medical Center, where he also directs the family medicine residency program. Though John and I have talked a bunch over email and on Zoom, one thing that stood out to me in John's reflections, particularly given the loss of autonomy many physicians have experienced, is his own sense of agency within primary care.
I've always thought primary care was one of the ultimate kind of energizing, kind of almost like we have this agency that we don't like to talk about, but it's there. Like if you're really in the community and you say, man, we have so many patients dying of overdoses, we have to do something about that. And we can do that. I remember we started an integrated behavioral health program probably 13, 14 years ago because so many of our patients had so little access to seeing psychiatrists or therapists, social workers. And so we wrote grants, we got funding for this, we hired amazing social workers to do this work. We had a great program director for our integrated behavioral health program, and he grew the practice from 3 social workers to 9 over the last 13 years, and 2 of them do mostly substance use disorders. That's been profoundly important. And we also started a Narcan distribution program years ago before it became kind of more widespread. And that's another program that I feel like people have great ideas and feel like this is what the community needs. And I've always felt like, yeah, let's do it. So I've always felt like primary care had this unique kind of way to energize people and to say we have agency rather than, oh my gosh, we can't do this or that. It really is kind of listening to the community and seeing what they need and feeling empowered to make a difference that way.
Yeah, it's interesting. I've always thought this narrative around not having agency is a self-fulfilling prophecy because as soon as people they don't have agency, then they can't see it where it exists.
Right.
But also, I want to talk a little bit about your mentorship and this idea of recognizing your agency, even when the whole world around you is telling you it doesn't exist. You were a resident at UCSF in their primary care program. You were chief resident there. And it was the early days of HIV/AIDS. Obviously, San Francisco was an epicenter. And primary care had a big role, as I understand it, in not just treating the people there who were suffering from HIV and AIDS, but in educating the whole country about what you could do. Tell us a little bit about that.
Training at San Francisco General at the height of the AIDS epidemic was profound. We were taking care of patients that were pretty much our ages, mostly men, and 80% of our inpatient service would be people with AIDS, cryptococcal meningitis, toxoplasmosis, all kinds of things that you never see anymore. And our family medicine residency program started an HIV fellowship. If you think about even in those days, how nascent the knowledge base for HIV care was, yet the leaders of our program, and Ron Goldschmidt was the person who put in so much work leading the care of our HIV positive patients. They felt empowered to do this. So even though you would have kind of like medical cultural issues saying, how can family medicine take the lead in something like HIV? His perspective was not, we're trying to take the lead. His perspective was, we want to make a difference. This is patient-centered, and we want to empower people out in the community everywhere that they can take care of these patients because they need help. I mean, they're not going to be able to see a specialist all the time. There's too much stigma, and primary care doctors are the people where people will go to and feel safe and feel like this is a place where I can get care. So he started this HIV telephone consultation service, and it was called the Warm Line. And it was a warm line, not a hotline, because it wasn't 24/7. It was in those days, it was like 9 to 5 Pacific Coast time. And this is also before computers. So we were trying to advertise this through medical journals, but it was staffed by pharmacists, PharmDs, family physicians, people in our residency program. There were residents and fellows. It was really great because we would get phone calls from people across the country saying, how do I manage this patient? And his goal was that we can help people, we can help primary care doctors, we can help family physicians take care of patients in their communities who need their help. I thought it was powerful. And then since then, it really grew into something, it still exists. It's now called like the National Clinician Consultation Service. And they do counseling and education for PrEP and all kinds of wonderful things, taking care of people with HIV co-infected with Hep C and addiction issues. But that all grew from this idea of saying, we can make a difference. We're family docs. And that kind of mindset of just saying, there's a need, we need to do this. Where's my part in this, in helping to make it go?
There's also a quieter part of agency that John touched on as well, whether it's doing home visits or calling his patients at night. And given that this type of work is often unrewarded by our system, I asked John what motivates him to keep doing it.
That gets back to that. What is the inside part of you that's deriving meaning and purpose from what you're doing? And that's not going to get external validation right away. Because I think so much of our current culture is based on external reward. The practice of primary care and medicine, as you've touched upon in this series, has so many external forces that are trying to drive us in certain directions. And I find that I share those frustrations too. But I know the patients really need us. And so when I walk into an exam room, I think it's probably just because I'm older, of course, and have experience, but I don't feel as compelled to make sure that I'm checking off all the boxes because I know the patient wants me for something else. And I always have the phone and I always have ways to say, I'll see you again soon, or we can talk about this later. And now we have the computer to email people, but the relationship and actually the visit is never over. It's just part of a continuum. And I think that that's really important. That piece of knowing that you're in a relationship that's going to have ups and downs. There's going to be highs and lows, but that's what patients appreciate, you being there for all of that and not being afraid of that.
I think a very useful framework for thinking about this distinction between chasing external measures of success rather than being sustained by meaningful practice is called self-determination theory, or SDT. For the sake of the podcast, I'm going to oversimplify. But SDT essentially boils down to the observation that humans engage in activities more willingly and more joyfully when three fundamental psychological needs are met. And those needs are autonomy, mastery, and relatedness. According to the theory, when we work in environments that support those needs, our motivation tends to be sustained and our performance better. In one viral post after Alysa Liu's performance, Steve Magnus, a writer whose work often focuses on peak performance, wrote, "Everyone wants to know the secret to elite performance. It's not complicated. Give people ownership. Let them bring themselves to the performance instead of squashing the joy and authenticity out of them." In the context of primary care, when these needs are unsupported, and when value is defined by superimposed measures, autonomy can be compromised, burnout can go up, and performance can falter. And while the theory doesn't hold up for everyone and everything, I do think SDT offers a useful framework for thinking about how best to sustain the parts of primary care that defy measurement. You already heard John talking about how the recognition of one's own agency can help physicians better meet a community's needs. The capacity to use one's agency isn't possible without some autonomy, meaning the freedom to recognize what really matters to the person or people in front of you. And though I don't think I can exaggerate the importance of autonomy to psychological well-being and, in turn, clinical care, if its importance were widely recognized in medicine, there'd probably be more resistance to tying primary care's worth to measured outcomes. Sudeep Bansal is a primary care physician who runs his own practice in Connecticut. But before he built his own practice, he was a chief medical information officer and chief quality officer for an accountable care organization. In that role, he worked to create value-based care contracts and helped physicians optimize their electronic health records so they could extract all the data necessary for value-based payment. Sudeep writes a Substack where he breaks down the flaws of value-based care in a very granular way. But I asked him to give us an overview of some of the high-level conceptual problems. The first one he described was the stark reality that it's far easier to excel on quality measures when your patients are generally wealthy than when they're holding down 3 jobs and struggling to put food on the table. And because social determinants aren't easily addressed by physicians or healthcare alone, one can give excellent care and still fall short on the metrics. But this specific challenge related to social determinants is just part of the broader problem I asked Sudeep about. So, how do we measure value? Can we measure value? And do you think that one of the problems with value-based care lies in the active measurement itself as an imperfect way to capture what matters to people and their health?
So when we're measuring value, I think the question becomes is value to who? Is that value to the patient or is that value to the person who's paying the bills? And that's our fundamental disconnect when we try to measure value. Today, all the value measurement is for the payer. Should I be paying for this particular test? Should I be paying for the Uber ride for the patient to be able to get seen? That's what we are trying to measure. None of this is for the patient. If you ask the patient, right, their measurement of value is how do I feel? Like it is very hard to capture that. So all of these measures are for the payers. And the way we try to do that is we want to measure outcomes on how patients do, but it is extremely hard to measure outcomes because outcomes are, did you die? Did you live longer? Are you able to do your activities of daily living? Right? Those are extremely hard to measure and they typically take decades to even manifest themselves. And nobody in any kind of contract, nobody wants to wait decades to find out if you made any money and how you're going to distribute the money. You want to have quick wins. So because we cannot measure outcomes, we end up measuring a process. That's where you get things like, what's your hemoglobin A1C? Are you prescribing antibiotics or not prescribing antibiotics for a upper respiratory infection? What are you doing for medication adherence issues? What's your blood pressure measurement control, right? You get all of these process problems. When you start measuring process, 2 things happen. It becomes a data collection issue and Goodhart's law comes into play. People start optimizing on how you can improve the statistic rather than improving the outcome.
In your administrative role, as you help practices with contracts or on, staying open, do you sense that people are sort of learning how to game the measures?
So I think people are trying. I think this is part of the reason why independent physicians are disappearing, because a lot of the independent physicians don't want to game or they don't want to learn how to game the measures. And they are the ones who end up losing in many of these contracts and they end up going and joining large organizations. And then these organizations are figuring out putting administrative staff in place to game some of these measures. So this is why you end up seeing consolidation in healthcare, because a lot of independent primary care physicians, they don't have the know-how to how to game them. And even if they do, a lot of them might be hesitant because you have direct patient relationships.
This consolidation has led to a tremendous loss of autonomy, but it also might be a huge waste of money.
Just the data collection issue, we've spent as a country, millions of dollars in just trying to collect all of this data for value-based care. I mean, if we just took that money and redirected it into the social determinants of health, we probably would have much better outcomes.
I asked Sudeep why, given all these problems, there still seems to be so much enthusiasm around value-based payment models for primary care.
Why value-based care continues to exist The best I could come up with is cultural hegemony. It's the dominant thought of the day. This was established by Atul Gawande's article. It has captured the imagination of everybody in policy circles, and it has created a groupthink. Because at a concept, it makes sense. And it is so complicated that for a lot of people, they do not want to scratch the surface and see what's really underneath it for two reasons. First, it is hard to understand, so you don't want to spend the time to understand it. And the second is, you're afraid that if you really understand it, it might actually shatter what you think about value-based care, and you might have to sort of live with the fact that actually value-based care doesn't work. So cultural hegemony is the best answer I can come up with. Why we keep talking about value-based care, is it going to solve the problems?
The Atul Gawande article Sudeep referred to is called The Cost Conundrum, and it was published in The New Yorker in 2009. The ostensible conundrum is how some doctors could spend way less money and still get better outcomes. In captivating details, Gawande describes the way financial incentives in a fee-for-service system drive up costs and compromise quality. And then he suggests that the damning question we have to ask is whether, under fee-for-service, the doctor is set up to meet the needs of the patient, first and foremost, or to maximize revenue. But some 17 years later, as you just heard Sudeep describe, there's no less incentive to maximize revenue. Yet Gawande's question is no less relevant to our latest approach to measuring value, meaning, is it the best way to set the doctor up to meet the needs of the patient? Though I obviously have my reservations about measuring value, a good friend of mine who I really trust is a primary care doctor and has worked in value-based payment design. And he reminded me how many patients fall through the cracks when it comes to basic performance measures like controlling blood pressure and diabetes. And even though it may seem silly to be calling people for the sake of meeting the metrics, he's been part of these outreach calls. And he told me, for instance, that when someone screens in for something like poor access to nutrition, he can connect that person to a case manager who has the tools to help. But though I think he's right that these algorithmic type processes can likely improve care for some, we're still left with this question about what makes for good primary care in a more holistic sense. The kind of care we all recognize as good when we see it, even if it's hard to quantify. Which gets us to the second tenet of self-determination theory, which is mastery, and will be discussed by our next guest, Sanjeev Golakota. Sanjeev's a primary care physician at Northeast Medical Group in New Haven, Connecticut. He'd written me an email about the critical skill set his training had engendered, and so I asked him to come on to talk about the nature of this mastery and its importance to primary care. He described a patient who'd come back to him after seeing several specialists for syncope.
The patient had difficulty, did not speak, could not hear well, he was deaf. So his wife was the interpreter for everything. They had concerns because he was having syncopal episodes and he was having frequent falls and they were worried. And one of the frustrating aspects, but they were such nice people, like they were so just kind of going along with it because I think they just thought that's how things are. But they had been seeing a neurologist for a seizure history. They had been seeing a cardiologist because they had a history of heart attack and stroke. And these visits were frequent because they weren't quite able to figure out why they're having so many falls. And when they saw the neurologist, he said, no, it's not seizures. We've done all the testing. You got to see the heart doctor. He sees the heart doctor. He says, no, this isn't ischemia. I know you've had a heart attack, so it's very serious, but it's not that. It must be a neurologic issue. But when I spoke to them, something else that I learned from my training came to my mind, which was the patient adequately hydrated? Which is kind of like a very obvious and in many ways simplistic thing. And even when I was bringing it up, I felt kind of stupid. Like, well, obviously this smart specialist and all these visits back and forth, and they had a previous primary doctor. So clearly they must have addressed this already. But I didn't really quite grasp just how much a language barrier, right? Not just not being able to talk, but also, deafness played such a big role. And so when I did discuss it with the patient, they're like, oh, yeah, we're not really drinking that much water, through the wife. And they were also on a diuretic, hydrochlorothiazide. So I made some changes and really pushed the importance of drinking water.
After Sanjeev explained this to them, he didn't see them for several months, and he assumed they were lost to follow up.
I thought, oh, I'm so stupid. Like, they must have thought they had the biggest waste of their time. This guy, doesn't know anything about me, saw me for the first time talking about something so incredibly stupid.
But then one day, they just show up in the office.
And I said, well, what's going on? And they're like, well, he's not having any falls. He's doing better. And I was like, well, why is that? And they're like, well, you told him to drink more water. You took him off the diuretic, which I think obviously did a lot of the heavy lifting there. But just drinking more water, they had no more falls, no more syncopal episodes. And I really just was so struck by that. It was really astounding to me that something so simple as communicating this important concept could have made such a tremendous difference for that patient.
The point of the story is not about the importance of oral hydration, though that, alongside stopping the diuretic, fixed the problem. What Sanjeev's actually getting at is something so much deeper about owning a patient's risk. And he's not talking about ownership at scale, like the way we think about accountability for a set of population health metrics. He's talking about ownership as a mindset of the person in front of you, something he learned from his training that he thinks has been gradually compromised in the last few decades. And honestly, it took me a little while to understand what he was saying because it's a bit counterintuitive. But as Sanjeev described his training program in Erie, Pennsylvania, which required the trainees to assume full responsibility for their patients' outcomes, I began to grasp what he meant.
It was what you call old school. Like, if you talk to doctors who did their residency in the 80s, early 90s, I would say that it's very similar in that regard. So first-year interns, we were managing the ICU on our own. We were managing the hospital beds on our own. It wasn't a large hospital. It's about 115 beds. But regardless, because of that exposure where we had all that independence, you gain something that I think is missing elsewhere. So things like admitting your own patients from the ER, managing those patients all the way through deciding if they need to be in the ICU. Do you have to do the intubation? Do you have to do the central lines? And making sure that you have access to the equipment, to the staff, to the support systems, making sure other patients were not going to crash while you're doing something like that, because you're the only doctor. Like, after we would round in the morning from 5 a.m. to 7 a.m., and they would be there till the afternoon. And pretty much after that, you're on your own. And especially at nighttime, you're definitely on your own. There was no other attending available. And so if something happened, you could call somebody by the phone, but you really had to do that, pretty much all of it on your own. And when you do a lot of those things on your own, you're kind of taking on a risk, and you're also kind of learning how to manage that risk because you have to make those decisions yourself. If you have a senior resident to turn to or an attending who gives permission, whether it's to admit someone or put them in the ICU or do a procedure, a lot of that risk is kind of removed. And when that's removed, you don't own the decision, you don't own, the outcome of that patient.
The counterintuitive part to me is how managing critically ill patients translates to primary care. Because a lot of internal medicine residents typically spend more time in the hospital than in the outpatient setting, it seemed to me more outpatient training might actually address some of the pipeline challenges that we have. But again, what Sanjeev's getting at is more of an ownership mindset. Partly that requires a trust but verify approach. For example, if a patient's blood pressure was low, he quickly learned to make sure it was being measured correctly. And that impulse now translates to reviewing all the primary data on his own patients so he can form his own impressions about whatever's going on. But what he really carries is a sense of totalizing responsibility for the patient contextualized within any system's inherent constraints. So for his patient with syncope, who had seen many specialists, even though he doubted his own assessment, He knew he couldn't just assume that the specialists were better able to identify the cause of the problem. And so I asked Sanjeev what we could do in our training or practice environments to support this type of mastery.
I would make sure training is hospital-based, like 100%. And as part of that, I would tell program directors that they have to give the residents tremendous amount of responsibility. The admission of that patient and managing him while he's in that hospital has to be the burden of the resident. And if we don't do that, then I think it's going to be a problem for how they are learning. And I think a big part of it is we just don't know how to evaluate risk from a qualitative perspective, because what we're doing isn't something you can easily numerically quantify. Even though they try to do it, you can't. That's where that gestalt comes from. That's why we come with all these words that are vaguely touching it, like art of medicine, right? It's not just, we know it's not just how we talk to patients and how warm we are. It's also this part where we just can't quite grasp what it is that we've internalized that helps us be better at our jobs.
Even though we're always trying to quantify risk, particularly in the context of value-based contracts, when it comes to the type of mastery Sanjeev's describing, his sense is that risk can't be measured.
When I look up risk and you look up like what is risk and it's, something that you can quantify, that's generally where most of the science is. When you look up qualitative risk, it's very rudimentary. Like here's a, survey, here's some questions we ask. But what people don't realize is all of our training is qualitative risk, like interviewing the patient and creating a differential and coming up, admitting that patient and making the decision what to do with them in the hospital. Do you admit them? Do you put them in the ICU? Do you intubate? That type of risk is what we've internalized. And if you remove that because you're worried about the risks to patients, then you've removed like the skill set necessary to actually reduce the risk to the patient.
Though I'm not sure I agree that primary care doctors should train solely in hospitals for reasons we've discussed, I completely agree about the critical nature of this sense of ownership. And I think it's increasingly under threat in today's practice environments. Chip Chambers is an intern at Self Regional's family medicine program in rural South Carolina. Prior to residency, however, he studied healthcare system design and got an MBA at Wharton. And when Chip reached out to me, he said something that captured both the necessity and vulnerability of this type of generalist mastery. What Chip said was, quote, "Primary care is not hard to do. It's just very hard to do it well." So I asked him what he meant.
Yeah, I think I saw early on a mindless way to do primary care. I don't mean to criticize people because I think some people are forced to this just by the system, but it ends up just being mindless blood pressure medication titration or mindless referring out as soon as you get a problem. And primary care just ends up being a high throughput triage center where there's no actual critical thinking or autonomy. But then I saw other doctors who really did it well, who knew their patients, who explained things to them, who thought deeply, their differentials were broad, their mastery of the medicine, they knew it stone cold and they cared deeply. And it was really hard for them to do that in the system in which they operated. And that was some of what inspired my interest in the system side of medicine. But when I got to see those physicians who I thought were just really good doctors, I said, wow, they're rare, but it's possible. And that was really inspiring for me, seeing people who, despite the pressures of the job, I thought really did right by their patients.
Yeah, and I think that when I think about what inspired me to do this whole series, it was my own sense that archetype, the doing it well, the consummate internist who knows everything and knows you and is the one you go to when you have diagnostic uncertainty or you want somebody to, quarterback care between the oncologist and the cardiologist and the thoracic surgeon or whatever it is. Like they have some sort of unquantifiable aptitude to do that. And I sensed that archetype was becoming a vanishing breed. And now I want to talk about the systems that you have studied and that you now operate within, because you said, that these people who are functioning with that level of mastery we're doing it in spite of the system, not because the system supported it. So when you think of system redesign, how do you think we can design a system that better supports that type of primary care, the good type? Because I do feel like we're sort of defaulting to the algorithmic type.
The structure of the fee-for-service system by nature, because of the RUC and the way it's been built, is that we price things based on the inputs that they require. So if something requires a highly technical, multi-hours long surgery with multiple people who took years of training to get that expertise, we price that thing very high, regardless of the quality outcomes for the patient. Whereas if something simply requires a few minutes of cognitive discussion in the office, we tend to reimburse that thing very low, regardless of how much that conversation matters for the patient. And the analogy that I think about is if I came to you and I presented you a shirt that was absolutely hideous and ragged, and I told you that it was $30,000, and you said, "Why in the world is that shirt $30,000?" And I said, "Well, I took 14 years to make it. Therefore, the shirt is $30,000. You would say, "Well, it doesn't, I'm sorry. I'm sorry that you wasted 14 years on that shirt. That shirt is not worth $30,000, regardless of the inputs that went into it." And so I think we have to step back as a system, and we may not have the political will or stomach to do this, but we have to ask not what are the inputs into these services, but what is the value of these services? And I think if we do that, we will see that relationships and care coordination and chronic disease management are ultimately the things that will give us the most value. And we might not ever be able to truly capture that. That is very difficult to get in an algorithm. But if we can have the moral will to do that, I think we will reallocate our resources in a very different way than we have currently.
Chip has also done some work in value-based payment design. So I asked him how he reconciles the sometimes algorithmic nature of value-based care with his understanding of what it takes to do primary care well.
I share some of your pessimism, and I think in some ways I believe it to be the least of the evils. I remember in medical school seeing a physician who I was working with who had built a long relationship with a patient on her panel. And the patient went to the ER, and the patient had long mistrust in the medical system and wouldn't talk to anyone in the ER. And the PCP called and talked to her while she was in the ER, ordered all of the tests that the ER providers would have ordered, and basically functioned as the ER provider remotely for her because she didn't trust anyone else there. And it was the right thing to do, and she got the care that she needed because of that trust. But the whole time I was sitting there, I was just going, she's doing this in spite of the system, not because of the system. Nothing in the system is incentivizing her to do this. She's going to be behind on her charting, and someone is going to get onto her for that, despite it being the right thing for the patient. I do think in a value-based care model, an activity like that is rewarded. You capture some of that value, that the patient doesn't go to 4 different ERs that day instead of 1. But I don't think it captures all of it. And I think that's one of the battles that we have to fight, is the temptation to justify that primary care is worth it because of numbers. I don't think we're ever going to prove that. I don't think that primary care is ever going to be cost saving, at least not in the short run. But the question is whether it's worth it, whether it's worth it to pay for, and whether we get enough bang for our buck. And I think the answer to that is an overwhelming yes. And so I don't think that we'll ever fully quantify the value of relationships or doing primary care well. I think that expanding our scope of what primary care is outside of an episodic fee-for-service basis gets a little closer, but I don't think we'll ever fully encapsulate the value of it.
As we've discussed a lot this season, failing to capture the value of trusting relationships isn't just a payment model problem. It's also a culture of medicine problem. And one of the more striking examples I heard about this was from Rob Epstein, a family medicine physician in Port Angeles, Washington. Rob's had a storied career, which included starting a family medicine residency program in Port Angeles. But because he practices broad-spectrum family medicine, which includes endoscopy, he moonlights in rural Alaska, where he's essentially viewed as a specialist rather than a generalist. And he's treated differently.
Since I've kind of in my phased retirement here. I have a little bit more time. So I actually do go up to Barrow, which is as far north in Alaska as you can go. And there I become an endoscopist for a week at a time. So suddenly I become a GI doctor, which is very unusual. I think, I have been a generalist for my whole professional career. And all of a sudden I've got other family doctors that are coming to me like I'm the gastroenterologist. And it's a really different feeling. I think that when you're a rural family physician, a lot of times you'll get on the phone with a specialist and they'll just say, why are you doing this way? Or, you should be sending that patient to me, in Seattle or whatever. And it's like, well, it's not that simple. One, the patient has to get there. And two, I just can't send everybody on to the specialist. But I think other family physicians that sometimes I realize that we've been kind of programmed to treat the specialists really carefully so that they'll treat us okay. And I don't think we always treat ourselves as well and really acknowledge all the different things that we do on a regular basis that are really fairly complicated.
The complexity Rob's alluding to is partly related to the need to integrate a patient's multiple medical and social needs over time. But often, that expert integration isn't possible without a relationship. Relatedness is the third psychological need of self-determination theory, and it's always been the aspect of SDT that's hardest for me to understand. In Alysa Liu's case, for instance, I can deeply understand how autonomy and mastery led to the beauty and joy that she exuded in her performance. But did she also need to feel a sense of belonging or connection to perform? I don't know. And yet, when I consider the need for relatedness in the context of primary care, it makes total sense. Patients want to feel known, and PCPs want to know them. Without that, trust breaks down, care becomes more fragmented, and the well-being of both patient and doctors is compromised. Brian Burke is a pediatrician in Little Rock, Arkansas, and he's written me a series of beautiful emails that capture the spirit of primary care, which in his case was general pediatrics, in a way that really moved me. I can't hit on all the ground we covered, but you'll hear him talk about how healthcare, in its quest for efficiency, neglects relationships. And ironically, this neglect probably leaves us, in the end, far less efficient.
One reason that we're not trusted is things are so confusing. I learned that there are actually people who make a living by being patient advocates, by going to the hospital and explaining what is going on for the patients. I do a lot of that in my retirement for my friends and for the people in my church, but I can understand why. And it's because the whole medical system needs to be redesigned with one question in mind: what is best for the patient? And I firmly believe that the general practitioner, family practitioner, general pediatrician, internist needs to be there in every step that a patient goes through the medical care system. And our system is set up for, quote, efficiency. Let's see as many patients as we can in a day's time. It takes too long to drive to the hospital. And I can see from a business model why that might make sense. But I think there's an efficiency that is lost. When you are there for the patient, when they're in the clinic, in the nursery, and on the ward, in the intensive care unit, if you go to the palliative care conferences that they have, maybe it's not efficient on that day, but the efficiency comes later because you have established such a bond with them. They know that you're there in every need that they have. So when they come to the office and you want to talk to them about preventive care, you want to talk to them about immunizations, I think you have a greater credibility and they're more likely to trust you with that. So I think the efficiency comes on the back end of things.
Brian also described the trust born of seeing people through tragedy.
I had been in practice like 4 months, and a mother who had just moved to the outskirts of our town and didn't have a doctor for her child. The child got sick. It was 3 years old. And she called the hospital operator, and the operator knew I was on call, so she sent her to me. And she said, "He's wheezing." And I said, "Oh, does he have asthma?" And she said, "No, he never has, but his daddy has asthma." And can I give him some of the Primatene mist that we use for Dad? And I said, well, I went through the rest of it, fever, vomiting, diarrhea. No, I put him to bed and he was normal, but he woke up wheezing and I think it's his first asthma attack. And I said, well, that's not necessarily the best drug. It's the first time the child's ever wheezed. I said, why don't you bring him into the ER and let's make sure we know what we're doing. And it's incredibly tragic because she lived 10 miles or so out of town. And when the child got to the emergency room, the child had passed away. And she vividly described an episode of when she got to the city limit sign, the child who was in her lap just went, oh, and the airway was closed. Well, it ended up the child had H. flu epiglottitis, and the airway had swollen shut, and it was still a few miles to the hospital from where that happened, and by the time he got there, the heart had stopped, and he couldn't be resuscitated. And that was such an awful way to meet someone. I mean, and of course, you can imagine how distraught the family was. But I went to that funeral because I don't know. I just felt like that was something that ought to be done and perhaps might provide some comfort. And she ended up, for the rest of the time that I was in Pine Bluff, bringing her children to me. And she would call the office and she'd say, my child's not that sick, but I'm coming in and Dr. Burke knows why. And I'll see you around 2:00. And if you don't have appointments, you'll just work me in. And so it was a real bond. And honestly, I think that mother and I had such a bond that she would trust me, if I said the vaccine is what you ought to do, or this is proper nutrition for a child, or this, I think she would have believed anything that I said.
What's so lost in our technocratic approach to primary care is the profound need for humans to connect to one another, whether in celebration or grief. And though I don't think primary care alone can repair our fraying social fabric, part of its immeasurable value lies in its role in fostering community. Andrea Anderson is a family medicine physician at George Washington University, and she's had a host of leadership roles across education and health policy. As you'll hear, she captures the critical role primary care can play in civic life.
I had an experience early in my career where a young boy, I was caring for the whole family, and a young patient within that family was tragically killed as a result of community violence. And several of us from our community health center attended the funeral. And it was really a high level thing. There was press, there was lots of people had heard about, this situation that happened. One thing that struck me was that I knew a lot of the other people at the funeral. I didn't really even know how different members of the community were kind of related to each other or knew each other. I saw several of my other patients at this funeral. Really highlighted to me how, community can be really intertwined. And at the end, I was giving my condolences to the mother and the family. And I said, is there anything I can do to help? Is there anything that you need? And she said, can you give us a ride home? And I was like, yeah, of course. Of course. We gave them a ride home and I piled like a couple people into my my little SUV and, took her to her apartment. And I felt so touched as a mother and a physician, but even to be able to be with her in that sense as her physician, it was beyond her clinical needs, beyond like the vaccines and the policy and all the things that we do, the metrics, right? All the things. It's a greater need that we fill as their primary care source. That's something that I always take with me. That my question, they were going to take the bus. Had I not said, do you need anything else? And that's what primary care asks.
When I hear people like Andrea telling stories, and I try to connect the dots between the conditions that allow primary care to thrive and the resources necessary to support those conditions, what has struck me all along is the fundamental lack of socio-political will. And as I've wondered about how to generate that will for primary care in the last several months, I found myself really fascinated by the public reception to HBO's Emmy-winning series, The Pit. For those who don't know, The Pit takes place in an under-resourced Pittsburgh emergency room, with each episode representing 1 hour in a 15-hour shift. Full disclosure, I've only watched a few episodes because I've been captivated less by the show than by people's response to it. A widespread embrace of the show's capacity to highlight such a spectrum of humanity, societal ills, and human connection in the face of illness. And all I've been able to think is, if they can do this so compellingly in the ED, doesn't primary care deserve the same? I wish I had the talent to write an award-winning TV show. But since I don't, I asked Andrea about the role of stories in rediscovering primary care. And she talked about how both stories and primary care itself make the invisible visible.
I think in highlighting those kind of stories and highlighting the cracks in the infrastructure that are making those stories fewer and far between, we can really rediscover the benefits of primary care. And I'm going to take it back to my primary care physician, how I went and told him when I was accepted to residency and accepted to medical school and all those things, how he was someone who I made sure that I told about that. Years later, I had a patient who I've been this patient's physician for many, many years. The patient actually ended up having some pregnancy complications, so was transferred to high risk pregnancy or high risk OB for the majority of her care, but still kept in touch with me, kind of situation where she'd call, like, hey, they want me to start this medicine. Do you think I should? I'm like, yes, please do. Whatever they tell you, go ahead. Anyway, after she ended up having the baby, she told me that the family had decided to name the baby after me because she said, you did so much for us and were such a source for us. And recently she put herself on my schedule. It was interesting to see her because I thought, I've already seen her for her physical this year. I'm wondering why she's coming in to see me. And she came in and she said, I just wanted to show you something. And she pulled out her stole, her graduation stole from high school, and she was the valedictorian of her high school. And she's like, I just wanted to show you this. I wasn't able to invite you, but I want to share this with you because this is as much yours as it is mine. And, I remembered that relationship that I had with my doctor when I said, I want to show you where I'm headed, where I'm going, and how you were a part of that for me, and how I told him I want to be that for someone else. So, it was a real full circle moment that I could be that for someone else. And that's why it's so important that we continue the fight for family medicine, for primary care. We stand in the gap, we make the invisible visible, and we help our patients feel seen as we walk with them through life.
It's one thing to make your patients feel seen, but when we think about the unseen work of primary care itself, I've wondered whether trying to make it more visible could compromise these immeasurable aspects of care we've been discussing. So I asked John Hahn about this quiet but essential work. I'm of two minds about this because I want it to be valued, but as you talked about earlier, when you attach external rewards to things, it can really compromise integrity. It becomes about chasing the reward as opposed to the actual, I keep coming back to this notion, but this like spiritual plane of connection and humanity that it's not what draws all of us into medicine, but it draws a lot of us. Sometimes that's silent and unwitnessed and certainly not paid for, but that doesn't make it any less valuable. And maybe that just has to be okay.
Well, it's a wonderful question. It's easy for me to go back into religious traditions, sort of, but almost, I would say all religious traditions talk about the value of doing the right thing when it's not witnessed. I mean, this is kind of like everywhere. It's in the Torah, it's in the Bible, it's in the Book of Islam. They value that so much because it's about integrity.
This quieter value isn't just about meeting patients' needs. It's about meeting those of the doctors as well.
I did a home visit yesterday on a patient of mine who's in hospice. And the last time I saw her was just before Christmas. And she said at that time she's dying of lung cancer. And I've also known her for about 25 years. And she said, at that time, my goal is to go to my granddaughter's wedding. And then I'd like to make it through Christmas. And she was able to do both. And so yesterday I drove out, just in a brief visit with her. But I think she feels and looks a lot different even in that short amount of time. And she was emotional and tearful. And again, she just said, thank you for being here. But then she said, thank you for all the phone calls and for checking up on me, because doctors don't really call people anymore. And that's really important. And I told her, you really mean something to me. I said, I'm here because I'm getting something out of being with you. I said, I'll call you again. And I'm sorry I didn't give you more advance notice that I was coming out to see you. And she said, no, I'm happy to see you anytime. And I will look forward to your call. And that statement of saying, looking forward to something, to somebody who told me minutes before she's just waiting for God to take her, that kind of like variance of looking at time was really powerful for me, but it also made me realize I think patients really get something just out of the presence that we're there, because they can sense when you care. They know what it feels like to be cared for, even if it's in 3 minutes or an 8-minute visit. You touched on this in an earlier episode about AI, like trying to train AI to sound empathic and stuff. I'm not surprised by that, and I'm sure it's kind of effective, but it's performative, and there's always a limit to performance, right? And oftentimes I'll tell residents because we're always focused on outcomes and metrics and things like that, and making change. And if they don't see change right away, they feel frustrated, especially at patients that are struggling with a lot of social determinants of health and things like that. I'll say, you know what? The very fact that you're spending time listening to them, caring, and want to do something and want to help them. So many people spend so much of their lives feeling like their relationships aren't great. They're suffering from mental illness or substance use disorders. They've been estranged from loved ones. And you may be the only relationship with a person that's demonstrating some degree of steadiness or consistency and caring. That's invaluable.
As you heard John say a few minutes ago, there are always limits to performance. And in that sense, this is maybe where the analogy to Alysa Liu really breaks down. Alysa Liu was performing on one of the world's biggest stages. And as we just talked about, so much of primary care, and really all of medicine, is about doing the right thing when no one's watching. But when I think about the future of primary care, the payment models, the policies, the relentless attempts to quantify its worth, I still think there's something that can be learned from her performance, even if it's now attached to winning a gold. Because what I've always loved about sports, and what I particularly loved about this Alysa Liu moment, is how it offered us this rare opportunity to be simultaneously electrified. How often in life do people get to come together from all walks of life and just celebrate? To feel the thrill of collectively witnessing something beautiful, unexpected, and yet totally life-affirming. Alysa Liu gave us that moment, and what I want is for primary care to get to have its cultural moment too. The thing is, these moments can't be forced. And I don't know how to resolve this tension between primary care's quiet, immeasurable value and the need for something loud to happen to make us see it. But what I can say is this. In the last several months, so many of you out there practicing primary care have taken the time to show me the beauty of what you do. It's a beauty that surprised me and that I hadn't seen before. I wish I knew how to capture that spirit and catapult it into the public imagination in a way that serves as a tipping point for primary care to finally get the resources it needs to thrive. But the truth is, I don't know how to do that. And so until then, all I can say is thank you for showing it to me. I'm Lisa Rosenbaum, and this is not otherwise specified, from the New England Journal of Medicine. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My article series on primary care can be found at NEJM.org, and our email is nos@nejm.org. I love to hear from you.